Okay.
It has started.
Thank you, Karen. Good afternoon, everybody. My name is Numi Rayfield Griffith, Senior Policy Advisor with the Department of Consumer and Business Services Division of Financial Regulation. This is our Rulemaking Advisory Committee that's originally started kind of just to make updates specifically related to House Bill 4149 from the current legislative session, and has kind of expanded it slightly to incorporate changes that are needed based on the past 5 years of legislation, basically. We did have some rule updates back in 2019 after the passage of House Bill 2185. And there's been several statutory changes since then. So one of the things we wanted to do is kind of go through and make updates to all the stuff that hasn't really been caught up. Let's see. Just to kind of, ground rules. I have a number of people who are official RAC members. Members of the public are also welcome to join, just to kind of let you know about who's on the list and who's not. Ultimately, the people I put on the list as formal members are people who replied back and said, yes, I'm interested in doing this. As a formal RAC member, people who are not on that list either never got back to me saying that specifically, but I've maybe kept them on as interested members of the public, or never responded or said specifically they just want to be listed as an interested party. So there's some of our usual suspects who are perhaps in the room but are not at the table, at the virtual table, so to speak, like Pharma, for instance, said that they would like to be counted as an interested party, but not as a formal RAC member for this. General virtual meeting etiquette applies. Welcome to be on camera or not, as you please. Please keep yourself muted when you're not speaking, so that we don't have feedback issues. And if you would like to speak up for any reason, please raise your hand, use the raise hand function. Karen is helpfully sharing screens, so I will be able to actually use that effectively, keep track of the order in which hands come up. And yeah, otherwise be on mute if you're not speaking. I sent around materials earlier this week. Sorry for the short notice on everything, so I'm totally understand if you haven't had time to go through the documents in detail yet. And we have a 2-hour block reserved for this. I have ambitiously written my agenda so it only goes to about 2:30 in the sort of aspirational goal of not being here until 3, but we'll see what actually happens. So with that, I'm going to go ahead and have us do quick introductions just so everybody knows who's at the virtual table. To avoid crosstalk, I'm going to ask people basically in the order that I have in my RAC list to just introduce yourself and the organization that you're representing. So first on my list is Lugina.
Good afternoon. My name is Lugina Mendez-Harper, and I work with Prime Therapeutics.
Thanks. Next, I have Maris.
Hi, yeah, my name's Maris Alden, and I'm here with Regions Blue Cross Blue Shield. Thanks.
Thanks, Maris. Jen.
Hi, I'm Jen Baker, Director of Government Affairs for Cigna, the Cigna Group, which includes Express Scripts.
Great, thanks, Jen. Lauren.
Hi, Lauren Sant, Executive Director of the Caring Ambassadors Program, representing patients in Oregon. And Madonna's having trouble with her camera. I don't know if you saw that in the chat. Don't know if Karen can help.
Yeah, well, sometimes Teams has a mind of its own. Speaking of Madonna's next. We can see if your mic is working, even if your camera isn't.
Well, let's try it. Can you hear me? Oh, good.
Yes.
All right. So sorry, my camera's not working. It just depends on the day. Sometimes Zoom, sometimes Teams. It doesn't like my camera. Anyway, I'm the Executive Director of Pacific Northwest Bleeding Disorders, and we represent all people with bleeding disorders in Oregon and Southwest Washington. So thanks for having me.
Thanks, Madonna. John Murray.
Hi, my name's John Murray. I'm an independent pharmacist from Murray Drugs in Eastern Oregon.
Thanks, John. Austin.
Nice to see you all. Austin Blakesley, Director of Pharmacy with High School Pharmacy.
Thanks for being here, Austin. Amanda.
Amanda Meeker. I'm the president of the Oregon State Pharmacy Association.
Thanks, Amanda. And Amy is our last.
Hi, good afternoon. My name's Amy Burns, and I'm a managed care pharmacist. Thank you.
Thanks, Amy. All right. So I remember the one thing in my ground rules that I forgot to say, which is kind of about scope. So what we're really looking at is kind of the four corners of 4149 and the things that are in existing statute and updates to reflect that. So we're not going to get into any conversations probably about upcoming potential legislation in the 2025 session or future sessions or changes that could be made there. I know there's proposals that are floating around, things that came up in Representative Nose's work group this summer, like the idea of basically replacing the MAC pricing regime with a cost plus pricing model instead. So we're not going to talk about that. I do make some changes in my draft to the MAC related terms, which would obviously, if that legislation passed, would probably be irrelevant in the future. But not to unnecessarily create work. I'm trying to clean up the law that we have in the hopes of kind of making things go as smoothly as they possibly can, even if we do not have additional legislation passed in the future. So that's just kind of one last set of ground rules. Okay. With that, I want to go ahead and get into the draft rule. So kind of the way I want to do this is to go over the proposed changes kind of by category. There's a couple broad ones I'll mention first, and then we'll kind of get into the more nitty-gritty things individually, basically in the order that the rule is in our ORs. What did I forget? I forgot to actually open my outline for my speaking notes. There we go. So the first thing I want to reference is there's a number of changes throughout the document which are related to sort of just very procedural minor things. One of the things that 4149 did is change our existing registration regime to a licensure regime. And so there's a lot of changes throughout the document as we're in the statute updating references to registration to references to licensure. So sometimes it's as simple as just changing registration to license. Sometimes it's using the term that is used in the statute, which is a license to transact business as a pharmacy benefit manager, which is wordy, but sort of an example of that is lines 20 and 22 on the first page are both places where I've replaced the reference to registration with a reference to licensure. The other thing that I'll mention is there's a whole bunch of places in our sort of current rule where we've had outdated references to the law as it was originally enacted. So like Karen is pointing out there, because we had adopted the original rule before there was an ORS number assigned. So there's changes throughout the document, which is just kind of changing references to Oregon laws to the reference to the appropriate ORS numbered section. And I think there's one example of that in the actual substantive text, which is lines 35, 36, sub E of the application rule, where I've replaced the reference to the Oregon laws, which came from 2017. This was the change that gave us authority at that time to revoke a pharmacy benefit manager registration. That since, of course, had an ORS number assigned, and so this just changes that reference to be pointing towards there. And what I like about this is it doesn't say registration or licensure in this part of the rule. So I can just change the statutory reference, and if they change the statute, then it will be updated automatically, basically. So luxury, save me future work. So those are the sort of big, that's the easy part. I'm open to discussion if anybody has any comments or questions about any of those items, the licensure and the ORS updates. Yeah, Lauren, go ahead.
So I just had a quick observation that ORS 735.533 still refers to registration and not licensure, so that might need to be updated as well.
Yeah, well, where were you looking at that? Were you looking on the legislative website or?
Yeah.
Yeah, so that's not my job, fortunately.
Okay.
So that will, so the changes from 4149 will be put into the ORS code in the future.
Okay.
By LC. So if you look at, I think it'll be the 25 edition of ORS, that'll have that corrected language in it.
Okay.
Something, at least one thing that is not my problem to fix. So other questions, comments?
Hey, Numi, this is Legina. Just a quick question, and it may be the same answer. So, and we can get into it when we talk about the specific sections, but like in here, it makes reference for like specialty drug and specialty pharmacy. It makes reference to ORS 735.534, but I don't see definitions of those two terms in 534. Is that because it just hasn't been updated, like what you were just talking about?
I might have put in the wrong reference.
Oh, okay.
Because
Sorry.
that's not a 4149 thing.
Okay, we'll get there. Okay.
That's from 2185. So I'd have to check.
Okay.
Like there was an earlier draft of these where I had some of the definitions I had copied over into the text of the rule. And that is not a preferable thing because like if we refer to the statute, if the statute is updated, then we don't have to change the rule. So that's sort of a drafting practice thing that came out during our internal review of the draft. So it's possible that when I put the references in, I referenced the wrong section of the statute. So I'll double check that. The specialty drug stuff, as I recall, I think that was from 2185. So I'd have to look and see where that is actually enacted.
Okay. Well, when we get there, I'll ask a question again. I just didn't know if it was the same situation where it was just a matter of the other folks that have to do this.
Yes.
Running a little bit behind you.
Entirely possible. That LC has other things on their minds right now, writing LC drafts for something happening next year. I don't know. Maybe there's a legislative session or something. Okay, so let's go ahead and blaze bravely forward. So I'll kind of go through this in order. 401, there's no changes other than statutory references. 406, we have changes which are related to the licensure change and the one change I referenced previously, replacing the statutory reference with replacing the Oregon laws reference with the statutory reference. 411 is just license language updates. 416. Okay, here we go. So there's changes which are related to licensure. The other thing that I have done here is I've added a reference to the TPA licensing, which is under 744-700 at sequence. So as this was, the language was previously, I'll finish my thought and then I'll get to you, Legina, is basically the reference was to, this is not exclusive of other registration or licensure requirements. It has a specific reference to business registration under the Secretary of State. I've added a reference as well to the TPA statute, almost by definition, by the way that PBMs operate. They're almost always going to also fall under the definition of TPA under that statute. We've had issues previously with having PBMs not being registered as both, registered as a PBM, licensed as a TPA. That was kind of something that came out in our early implementation of the PBM law, was finding entities that were not licensed as TPAs, even though they were registered as a PBM, and kind of sending corrections to get that done. So that's kind of way back in history. I know there's been some concerns brought up previously and possible legislative changes about wanting to make the licensure requirement exclusive. So like if you're a PBM, you don't also have to get a license as a TPA. My view on this is that we don't actually have the authority to do that by rule, because there is no discretion language put into the statute that says we could exclude somebody from TPA licensure, that we basically are stuck with the dual licensure regime that we have right now, absent a statutory change. So I just wanted to add that language in to make it clear that we do expect dual licensure, and that has been the state of the law previously. So to avoid confusion. Lugina, did you still have a question, or did I answer it?
Oh, no, sorry. I just want to ask a question about how you want to run the meeting. Do you want us to ask questions at the very end, or as you're going through sections?
Let's, why don't I give my spiel on each section or subsection, and then we can open it to discussion, if that makes sense.
Thank you.
Cool. Any thoughts on this change? I mean, I think it's non-substantive ultimately, but it is related to a topic that has caused fur to fly in the past in the legislature. So thought it would be worth visiting. Okay, not hearing any. I'll go ahead and forward. 418. So this is our updates to the transparency statute. We have a couple of folks on the call from the program team, which runs drug price transparency, in case any issues come up in terms of implementation that need to be addressed. One thing, of course, I'll mention, of course, this is a very first draft, so it's entirely possible that things like statutory references may be incorrect, as we discovered earlier, but we'll get to that in time. So there was a couple of things added to the transparency annual reporting requirement originally put in place by Senate Bill 192 in 2023. The additions are basically related to spread pricing, kind of separate terms that could permit comparison and validation of spread pricing practices, and reporting of administrative fees. So that's what's in 4149. The way that I put this together, so I've got statutory references back to the definitions of spread pricing and administrative fee. I see that I am missing some quotation marks there. So yeah, getting the work done. So that's one thing that I will fix for sure. Missing the quotation marks at the end of administrative fee for the definition. Of course, I can't edit this. It's a PDF. Okay, I'll fix it in my master document. Okay. Sub 4, which I've renumbered, has reference to licensing added. So kind of to explain how I've done this. So getting down to 4A, there is this additional text that I've added here. This is not new. It was in the rule already from the rules that I drafted implementing 192. It was originally, I think, down in a separate subsection 5. And so the reason that I've changed this is because as it was originally drafted, we had things that were only related to rebates and the possible pass-through of rebates. That was everything. And this language was basically designed to reflect legislative intent, which was an interest in capturing kind of all monies in terms of rebates that were flowing into PBMs, even if there is corporate complexity to the way the transaction was set up. So we had some debate about this back in the 192 RAC, and ultimately we went ahead with this language. We haven't had any issues with implementation so far. So like, I think it's okay. I've moved it out of subsection 5 into subsection 4A because basically what I'm looking to do is apply the same language to the categories so that I have subsection 4 is a sort of top line that then has all of the different data elements that must be reported. The new data elements don't have the same logic applied to them as with rebates. What the concern with rebates was about that there was a concern raised in the legislature about these entities referred to as rebate aggregators that are sort of third-party entities that are corporately affiliated with a PBM. And the concern was that a PBM could use this third-party entity to receive rebates and thereby avoid reporting. And so that's why we brought this language in. So this applies to that old original reporting language, which now is under sub A, B, and C. And because B and C refer back to A, that carries on downwards. The new data elements, which are under the newly added sections E through F, are things where the same logic doesn't apply about the concern for rebate aggregation or sort of third-party information, at least in my mind. I could be wrong, but where I didn't think it made sense to kind of include that same carry-over language in terms of what our expectation is for the scope of data to be reported. So that's what that change is. I'll go ahead and kind of go through, because I've organized the language slightly differently than it was written in statute, in terms of adding a little bit more clarity on what we think that each of these data elements is going to be. So E and F, dispensing fees. So E, I've described as dispensing fees paid in the state to pharmacy benefit manager by payers. And then F, the total dispensing fees paid by the PBM to pharmacies by the pharmacy benefit manager. My read of the statute is that the intent here was to get a data validator for reported spread pricing, because that's kind of what was discussed as the thing, as what spread pricing is in the legislature to some extent, and Representative Nose's work group, is that a PBM is taking spread by paying pharmacies less for dispensing than what they are paid by the payer, the insurer, the CCO, the employer, whoever, for dispensing. And then that difference is the amount that it comes out as spread. So that's what E and F are. The way that it's written in the statute is total dispensing fees paid to PBMs and pharmacies, which is why I've broken it down there, because like I'm trying to reflect the purpose of the statute while stating it in more plain terms what we actually think that means and making it more clear why it's there. And we have administrative fees obtained by the PBM from manufacturers and carriers. I believe I should add a reference by the PBM just for consistency. So that's an edit that I'd like to make. And total amount of revenue obtained by the pharmacy benefit manager through spread pricing, pay for performance arrangements, or similar means. The one question I have in my mind here is whether we need a definition for pay for performance arrangements, or whether we would like to include some sort of language that clarifies an expectation of what similar means in this case, because I don't necessarily have an idea of what we would want to consider to be within that bubble and what's outside of that bubble, if that makes sense. Sort of my thought had been that we have the sort of two provisions related to dispensing fees that allows us to calculate spread pricing, and then we'd be able to compare it against what's reported in F in terms of reported spread pricing. But maybe I'm missing something because I didn't write 4149. I read part of 4149. I didn't write this part of 4149. So I'll stop talking and see if anybody has any question about this, questions, concerns, comments. Madonna, go ahead.
So it looks like you have two E's and F's. Am I looking at that right?
Oops. E, F, G, H, I. Yes. That is the letters in the alphabet. Thank you. That I need to fix that.
And then I kind of have to agree with you. I think we do need definitions, but I'd be happy to hear what the rest think. But I think definitions would be helpful.
Thank you, Madonna. I see a nodding head from Lauren, and I see a hand from Legina. Go ahead.
Just a couple of questions. So you said that the E and F that talk about dispensing fees, that your intent here is to try and have a spread qualifier, but I just want to talk about the total dispensing fees paid to a PBM would be, so a dispensing fee is paid to pharmacies that are dispensing drugs. So when I read total dispensing fees paid to a PBM, I thought and what we would have reported is any mail order claims or specialty claims that that we had dispensing fees paid to us as a pharmacy, that's what we would be reporting. I think there may be some confusion between what a dispensing fee is and then what the administrative fee is, because I think administrative fee is really where you would get at a spread issue. Does that make sense?
Yeah, no, that makes sense to me. So like in terms of dispensing fees paid to PBM for purposes of dispensing through a subsidiary or through rather than
owned pharmacies. Yeah.
Right. Okay. Okay.
Yeah.
No, I hear that. I mean, I'm not sure if that tracks the legislative intent necessarily. So I would want to kind of check with our legislative sponsors and see what their thought is, and also maybe with some of the advocates who were pushing for 4149 and see what their hope was for this, because like I can see an argument in either direction. It's just, yeah.
Oh, right. And again, I'm not saying that we wouldn't report it. I'm just saying that dispensing fees is a fee that's paid for dispensing prescriptions. But I think what the legislative intent was trying to talk about and spread again would be the administrative fees, that's where you would see as opposed to looking at dispensing fees, because that's for dispensing drugs. The other question that I had is and this is just a general question. So if you go back to page 4 and line 108, where it's the first part of like what we have to report, and it says that we have to report the aggregated amount of rebates, fees, price protection payments, and any other payments that we get from manufacturers. So the question that I have is that because fees is listed on 108, my question is the fees that are reported in your new EF, in your, let's see, current G and current and now H. I'm just wondering if that's going to be double reporting of fees.
I don't think so, because of the way that it's defined in the original statute is the counterparty in that transaction is the manufacturer specifically. So fees paid, but rebates like sort of like my understanding of that language was as introduced like we wanted rebate reporting, but we also wanted to avoid a situation where you're calling a rebate by another name. Not to say that Prime Therapeutics would do that, but at least that there's concern about some PBMs engaging in practices to reclassify things or treat things in a way that would exempt them from that. So that those sort of additional terms in there are designed to capture payments from manufacturers, whether or not they're called a rebate, and even if they're structured in a way that is not rebate-like. So, like, I think that's what's there.
Yeah,
and like,
you have
I think
dispensing fees, administrative fees, but then that you have that darn little fee that's up in the rebate mix. So, anyhow, that was just a question.
Yeah, I tend to think that it is just the connection back to manufacturers that makes the distinction here, but you know, that's. Let's go to next hand I see is Jennifer Baker.
Hey, Naomi. Thank you for this discussion. And I just kind of want to back up the question that Lugina had on dispensing fees from insurers to PBMs. I'm not sure that you would get anything. I mean, I need to obviously look into this, but like we don't bill the insurer for a dispensing fee. So, I mean, you could put that in there. I don't know that you would get anything in a report. So that's why I think she's saying administrative fees. But, you know, again, I would need to clarify that. I don't know. I see what you're trying to get at. I see what the information you're trying to gather is how much does the insurer pay to the PBM, and then thus the PBM pay the dispensing fee. I get that. But again, we don't bill the insurer or the employer for a dispensing fee. It's in their rate. The other question I have is, so this all applies to fully insured Oregon plans, correct? So
Yes.
like, again, the total amount of revenue obtained by the PBM would be for fully insured plans in Oregon.
Yes. So, well, no, caveats. So caveat for more things is that 4149 changes the definition of the PBM subject to the law to also include PBM serving CCOs. So that is an expansion relatively. So it would be PBM serving CCOs and PBMs serving commercially insured plans. The other caveat that I need to put in there is that as PBM is currently defined in the statute, it doesn't apply to insurers or carriers that directly administer their pharmacy benefit. So an insurer that is not employing a PBM.
No, I mean, I would just say, because that's their data, right? Not, okay. Yeah, okay.
Yeah.
Just
Because so that is the one caveat for yes, commercial plus a bit more, and a second caveat, yes, commercial, but actually less than we think it is.
well, yeah, and the CCOs is a good point. I forgot about that. So thank you.
Yep. Next I have Amanda.
Yeah, I think the intent of this part was to report the total amount that was paid for the dispensing of the drug to the PBM, and then how much of that was paid to the pharmacy. So I think we're getting hung up on the dispensing fee part, but it's the total cost of dispensing the drug was, I believe, the legislative intent.
Okay. Yeah, so it is connected back to the spread pricing sort of idea is what we're looking to expose here, or is there something else that I'm missing?
I mean, that's how it's under retained as revenue by the firm. Oh, just kidding. Yeah, I mean, that's how I read it.
Okay. Yeah, I'll revisit this and certainly kind of noodle on things with council and with our internal folks and see if we want to tweak this at all, and we'll bring it forward to the next meeting. Next I had Amy.
Yeah, hi. I think that I was listening to what Jen and Amanda said. I think we're all kind of looking at it through slightly different lenses. I think having definitions for this would be really, really helpful. Because I read that dispensing fee and I don't see reimbursement for the drug in that. So I could see that that's maybe what they were trying to get at, as Amanda was saying, but how it's written, I would take that directly as dispensing fee, which, you know, there might be some really interesting data in that, depending on whether or not there's a full pass through there along the chain. But I think that getting clarity on that, as well as some of the other terms that are being used, and obviously like talking about fees, that's going to be really important, would be good.
Yeah, thanks, Amy. That's helpful for me in thinking about this. Okay, I have one more hand up, so I'll get to John and then I'll have my response, if any.
Yeah, thanks, Damian. I'll just be short. Amanda expressed what I was hoping to say, so thank you.
Okay, thank you, John. I think what I'll do is I'll take a look back at this section and kind of cross-check against the statute, as well as talk with our internal folks who run drug price transparency and kind of see what we can shake out of this language in terms of like recognizing that maybe what was actually enacted in the statute is not necessarily going to reflect what we wanted it to, or what the proponents wanted it to, that there may be a mismatch between the sort of dispensing fees or paid to PPMs, since that the whole reason I probably got into this in the first place was because dispensing fees paid to PBMs also did not make sense to me. And so that's kind of why I tried to put it into this frame. So maybe there's something there. Certainly possible that a statutory change is necessary if that there is confusion over what the actual meaning of that is. But yeah, definitions would be appreciated. So the one thing I would ask for is like if people have an idea of how you would like to have pay for performance defined, if at all. And if anybody has suggestions or think that there's a desirability for a definition of similar means for the purpose of this rule. Amy, yeah, go ahead.
I'll just say that you can probably that already exists within the Oregon Health Authority definitions for pay for performance, dispensing fees, all of that is available. I'm not representing a CCO, but I work for one, and it's all within the contract. Those are all pretty clearly defined. So I would suggest perhaps for alignment purposes that you use pre-existing definitions for the state.
Yeah, no, I appreciate that. That's a good call out. So I will take a look at the what is that? The public health section of the code. I tend to live my days within the four walls of the insurance code, so it doesn't always occur to me to look other places. So that's a good call out. Why don't we go ahead and move forward, since I feel like I have a lot more work to do on this one. So maybe it won't be super productive to continue beating this particular dead horse today. So let's go ahead and move forward. 421, again, it's registration for licensure. No changes to 436. All right. The big tamale. 440, market conduct requirements. So I think with this one, maybe I'll try and go maybe section by section to a greater section within this rule, since there is a lot in it. And again, this is very much a first draft. So where to start? There's an easy one. Subsection 3, I am replacing reference to Oregon laws 526. That was 2185 back in 2019 with the appropriate statutory reference. And this is the statute specialty drug definition that I think, Legina, you called out earlier. So I'll double check and make sure that we have the correct statutory reference there. I think that's the only definition in here. And then there's the specialty pharmacy reference under sub 4. So again, I'll check the the statutory section to make sure I have the correct reference. Okay.
Numi, this is Lauren. I put in the chat the definitions that were in that ORS for specialty drug.
Okay.
I put them in there so you could see that they are in there.
It is under it. Oh,
yeah.
Okay. It is under 534. Okay, good. Well, that's helpful. That will save me a headache. I mean, I guess like the sort of quibble would be to say that maybe best practice for clarity would be to identify the subsection where the definition is, but yeah, anyway. Thank you for catching that. You have a keen eye, which I do not always. 735.530, Sophie. That's where that is.
Yes, that's the definitions that are being quoted.
Okay. Yeah. So I do need to update the reference. Okay. Okay. So there's a few things in here. And we are at 1:45. So depending on how long it takes to get through this, maybe we will actually get done within the timeline that I had hoped for. And I do have on the agenda time for public comment at 2 o'clock. So I will go ahead and pause my discussion and see if there's any desire for comment at that point, and then ask again after we get through the full agenda to see if there's any residual public comment at that point. So yeah, so on page 8 and 9, subsection 7 of this rule. So this is maximum allowable cost pricing. And one of the things that I was looking to do here is to clean up the rule that was enacted after 2185 in 2019. 2019 House Bill 2185 did a couple of things, and it also set up kind of a rulemaking process which negotiated out some changes to our the way that we are supposed to, or the way that PBMs are expected to handle complaints about or handle appeals of MAC pricing. And so there's a bunch of language that was put into the rule about what is it? Business need. So whether a drug is available to a given pharmacy at a MAC price. So MAC pricing, again, like the sort of ceiling for payment from a PBM for generic drugs. There's a number of requirements in the statute about how frequently MAC needs to be updated, the sources that are used to well, actually, I don't know if there is anything in our statute now that I think of it. There is in other states. But the concern, like really getting back to 2013 with this policy, was the concern that drugs reimbursed under maximum allowable cost were frequently reimbursing pharmacies, particularly community pharmacies, for less than their cost to purchase a drug. And we're still having this discussion 11 years after that law was passed. So I would say that what we have done so far has maybe not adequately addressed that problem. One of the things that was done in the wake of 2185 was the addition of some language that said basically a network pharmacy can still appeal if a drug is only available at MAC pricing if purchased in substantial quantities in excess of business needs. This is not language that is from statute. This was language that was negotiated in the rule after passage. So as it was originally written, there was basically just the provision that said you can appeal in a circumstance where it's not available to you as a pharmacy if you have to buy it in way more than you would actually need. So as a community pharmacy, if you're being effectively forced to buy way more of whatever drug it is in order to be able to get a bulk discount and to be able to afford that you could then go back to the PBM and say, hey, no, like I really can't purchase this. And kind of what this is looking back to in the statute is an idea of what is available to a similarly situated pharmacy. I'd have to go back and look at the language to be completely sure of what it says. But really trying to dial down into what does it mean for a drug to be readily available to a pharmacy at that price. And maybe I need to clean up or put this in a definition to kind of get that clarity. If generally available for purpose. Yeah, it was under 7355341A B3. A drug is not generally available for purchase if the drug is available to a pharmacy at a price at or below the maximum allowable cost, only if purchased in substantial quantities that are inconsistent with the business needs of a pharmacy. So that is actually in the statute. Now that I'm thinking of it, it's just not where I expected it to be. And so really kind of what we're looking to do here is to clean up the MAC appeal language. And so how I've done this is I've preserved the language that says, hey, you can appeal if your reimbursement is less than your cost. And if you're denied on a basis, they send you an NDC, you can appeal that on this sort of business need basis, if that makes sense. So that's what I've got as sub A or sub B. So sub A is the sort of initial appeal. I got paid less than it cost me to buy this drug. The PBM sends back a denial that says, no, here's an NDC where you can buy at this price. And then you can appeal again under sub B to say, I can only buy it at that price if it's like way more than I need. And then I've also tried to put the language that is about the expectations of what a PBM does in both the case of a denial and in the case of a granted appeal, because like I think there's been some not non-compliance, but maybe confusion about the sort of expectations. So that is, where is it? Subject. Okay, under sub A, if a PBM denies an appeal, you have to provide the reason for the denial and an NDC that could be purchased by similarly situated pharmacies. And then sub B, you can appeal that under the business need language. And then sub C, if it's granted under either of those bases, so either under the initial appeal, it was under cost, or the secondary appeal, it's under cost unless purchased in excess of business need, then PBM needs to make an adjustment to the pharmacy and allow the pharmacy to reverse the claim and resubmit. So all that's from the statutory language. So I've tried to take kind of what's an existing confusing, messy regime and put it into something that actually makes a little bit more sense in the rule. I don't know if I've succeeded at that or if I've just confused all of you, but I'll go ahead and pause there and see if we have any discussion about this sort of proposal. Austin, go ahead.
Couple thoughts. Can you hear me? Yes.
Yep.
the intent, I think, is for them to tell us, no, the MAC appeal was denied because you can buy this NDC, but there's no language in here saying where it could be purchased. I feel like that is helpful information for the pharmacy to know, because the point is not, I mean, is the point to penalize the pharmacy, or is the point to educate the pharmacy so that they can be all on the same board, same, page as what the PBM is buying at? I think that's probably the idea. So educating the pharmacy where they could have purchased the product is helpful information. And then something else to add to the sufficient quantity or like excessive quantities for the business needs section. There's two other scenarios that I think are helpful to include are if there's subject to an order minimum, so that I don't know if that's included in the you got to buy however many, but then also inclusive of any delivery fees. Like there's one supplier that we use rarely, but they have a $100 minimum in order to get free shipping. So if you're not ordering $100 worth of product, then you got to pay for shipping, which would get rid of the benefit of buying the drug at that location. Then even if we're paying a little bit more at our wholesaler net, it's cheaper to buy it at our wholesaler because we don't have to pay for shipping. So I would say inclusive of delivery fees or whatever. And then lastly, I don't know if this is included in what we're doing here today, but there's currently no penalty to PBMs when there is a MAC violation, I guess. So in essence, there's nothing stopping them from saying, well, we're only going to pay you $1. And then when we file a MAC appeal, all they do is say, oh, yep, sorry about that. We'll give you $3 more. So there's currently no penalty. So is that within the abilities of what we're doing here to include a penalty paid to the pharmacy for that?
So thanks for your thoughts. This is very helpful, Austin. A couple of things, because you had a few questions for me and kind of a few ideas that I want to respond to. Sort of first thing, like I appreciate the idea of providing a wholesaler, the name of a wholesaler that you can actually purchase at MAC. And I mean, I wonder, I don't want to get into a description of Oregon administrative law here. But one of the things is that as a state agency, we have a relative level of flexibility based on what the courts have said about the limit of our authority is, what has been granted by the legislature. Oregon is a state that we are very limited in what we can do outside of the bounds of statute. So one of the things I'd like to say that we have authority to make rules where it's been said we have the authority to do so. We do have a sort of general grant like that for PBMs, but also that we're only really able to do that where there's sufficient ambiguity in the statute that we can kind of fit in and say, hey, like, here's something that isn't adequately addressed in the statute, or this is vague, this is unclear, this needs to be defined. Things like what I was talking about earlier with the sort of, spread. What does spread pricing mean? What does administrative fee mean? Like those are things that we can issue rules to define terms where it's unclear. I wonder about so I appreciate the idea of and the feedback of saying, well, it's not enough to provide an NDC. You also need to be able to know which is the wholesaler that is offering that NDC at this price. I'm trying to see where this is in the statute. So like I would have to look and see if there is kind of a gap in the statute that I'd be able to fit that into, if that makes sense. And if there's not, then that would be something that we would need a statutory change to actually do. Let's see, shall not refuse, must be completed by request for an adjustment. Upheld. Appeal is denied. Reason for denial, NDC of a drug that may be purchased by similarly situated pharmacies. Yeah, so I wonder kind of digging into the sort of logic of what does available for purchase mean. And both of the things that you referenced in terms of being able to identify the particular wholesaler, maybe that is something that we can fit into that. And saying that something is not generally available for purchase if it's subject to a minimum purchase requirement, kind of like what you were referencing. The stuff about like delivery fees and things like that, I feel would be a little bit more difficult, but I'll process that and kind of see if there's room and if there would be interest internally in kind of moving forward with that requirement. We do not have a program staff for PBM enforcement yet. We have a manager who was just hired, but but I'll consult with him and see where we're at and thinking about how we would like to move forward with this particular item. Okay, so I addressed one thing. So I talked about the first things, which was kind of generally available for purchase, the sort of identifying a particular wholesaler and the additional fees. And the other thing was the volume, the sort of requirement to purchase a specific amount. What were the other things that we talked about? Oh, penalties, yes. So we have penalty authority over PBMs under two sections, one of which is that we have authority to revoke a license. I'm not sure how meaningful of a stick that is. Like, I don't know that we at DFR would come in and say, CVS, Caremark, you can no longer do business in the state of Oregon. That doesn't seem tremendously realistic to me. But we do have penalty authority for any violation of the insurance code. All of these things are under the insurance code, which is up to $10,000 per violation. The way that we the way that we implement that is that we usually count violation per claim or per incident. So, if you send me a spreadsheet that says, here's 10,000 claims where we were reimbursed under cost, we did a MAC appeal, and the PBM didn't comply, they didn't send us an NDC, or they didn't redo things, each of those would be a separate violation. And then for however long that continued, every additional day would be another violation. So $10,000 doesn't necessarily sound like that much money until you stack it up. And then it can be a fee that is actually, it could then be potentially a fine that is meaningful to an organization like CVS, say. So that's that piece. I know that there's been some issues in the past with the way that we've been able to respond to PBM complaints because we are restricted in our ability to communicate back to the complainant pharmacist by HIPAA. And I've been talking with our new manager a little bit about whether there's any way that we can improve communication with pharmacies who've sent complaints to us following a MAC appeal, especially if the volume is increasing after 4149 is in effect. But that's not really settled what that's going to be yet. Because I know that's been a problem, is kind of you send this MAC complaint off into the ether, and then maybe it's hard to see what's actually happened there. Like it looks like we're doing nothing, which is not true. We are doing something. We might be doing it slowly because we are the state government, but we probably are doing something. We're just not necessarily always able to communicate back to you what's happening there. So I recognize that there's issues and there's a perception that the laws that exist hasn't been doing anything, and those are things that we would like to address. Was there anything I missed, or is that pretty much all of it?
Well, just one last thing is that the PBM must make an adjustment for the appealing pharmacy. My question is, why is it just the appealing pharmacy? Why is it not all pharmacies? That if it's wrong for this pharmacy, why are they allowed to continue to perpetuate an injustice to other pharmacies?
Yeah, there is some language in the that it's supposed to be limited to similarly situated pharmacies, and maybe the intended approach is that it's like, okay, if High School Pharmacy sends an appeal, well, that's a bad example. There is no other pharmacy in Oregon exactly like High School Pharmacy. If Murray Drugs sends us an appeal, then we'd be able to say, so similarly situated pharmacies, other independent pharmacies throughout Oregon. That's kind of the scope of that, but it doesn't extend to what's a chain pharmacy that's not CVS. Fred Meyer. It doesn't extend to Fred Meyer. It doesn't extend to Walgreens. So that's the sort of limiting factor. That say we don't apply if there's an appeal, if it gets upheld for an independent pharmacy. Okay, we'd apply it out to other independent pharmacies, but we're not going to give the same deal to Fred Meyer, unless Fred Meyer comes and sends a complaint and says we're not able to purchase at this price either, which would be shocking, right? But, you know, maybe that's a consideration then.
Okay, thank you.
Okay. Jen, I've kept you waiting far too long.
Ugh, with rest that is baited. No. So there's a lot going on here. I kind of wanted to, you already said something, but I just want to reiterate that different pharmacies have different needs, and obviously different, you know, pharmacies have different business needs per se. And you did the perfect example. A Kroger has different needs than a high school pharmacy. So obviously it should be dependent on the appealing pharmacy based on the circumstances of that particular appeal. And, you know, so thank you for that. So I wanted to just kind of address the delivery fee thing, and then also maybe ask for an additional request. So if you're going to include delivery fees along those lines of looking at the entire drug supply chain and the cost, we would actually also like language in the rule that would require the pharmacy to include any invoice discounts that are received from PSAO owned, or no, I'm sorry, wholesalers like McKesson. So because we think that does play a role, and we obviously had this discussion in our PBM work group, but that plays a large role in the ultimate price of a drug. And so those should be included too, because I think that without those invoice discounts or rebates or whatever you want to call them, however you want to label them, should be a factor in what a pharmacy is actually being paid for the drug. Because again, we don't necessarily know what the invoice discount is specifically for that pharmacy, but we know that they exist. And so part of MAC pricing may include those calculations. So that would be a factor to include as well. Again, if we're looking at the entire drug supply chain. And I also just wanted to add that the penalty is very, very real, and we know that it exists. And losing our license would not be fun. It would not be a good thing. It would be a bad thing for us, but mostly for consumers. And then, you know, obviously, penalty fees and fines are very something that only just raises the cost of care ultimately. So, which we don't want to do. So that's all I have.
Thanks, Jen.
Do you, I mean, well, other than to say, can we include those invoice discounts in that?
Certainly I can look at that. Like the sort of instinct that I have at this point is like whatever this ends up being, it is going to need to be something I fit into the sort of what is readily what's the terminology? Generally available for purchase. What does that mean? And kind of pushing on the boundaries of what that means for independent pharmacies. So like certainly lots to consider, but yeah. Legina, go ahead.
Just a quick question. On line 234, this is just one example of it. It talks about the MAC appeal. This is the MAC appeal process, but it says that they can a network pharmacy may appeal its reimbursement, and you took out from a PBM, and it's in other sections as well as far as. But I just want to clarify, this is talking about the PBM process that's required as opposed to the right? I mean, I just wanted to understand why from a PBM was removed.
Yeah, I'm not sure exactly why I would have done that.
Can I make a suggestion, Numi,
Yeah.
on that? Well, I'm wondering if it's because there's certain health benefit plans that don't use a PBM but act like a PBM. Maybe that's why that they could file an appeal regardless of whether it's coming from a PBM or not, because there are health plans that act like PBMs and do have, you know, MAC pricing that's implemented, but they aren't regulated by the state necessarily because they're not
yeah.
a TPA per se.
Yeah, I mean that is kind of getting back to the issue of what our PBM definition in the state means, and the fact that all of these laws under 735, 500 refer back to that definition, and that it does exclude.
I mean, this has no impact on us or other PBMs. This would just be on health plans that process their own drug benefits. And I'm assuming that independent pharmacies are going to want to be able to appeal a drug cost regardless of what
Yeah, I mean, like they're not in the room, so I'll go ahead and say, like, Providence and Kaiser, as they currently exist, are not subject to any of these things. And so it would not be my intent to revise the rule in a way that implies that we are expanding our authority over them in that way. If the legislature decided that it was desirable to include Providence and Kaiser under this, like that's their purview. That's definitely outside of our authority as the state agency. So I'm not sure why I deleted that. It doesn't make sense. I should put it back in. And really the only guess that I have is because, like, I had my revisions, I had my red line, I had back and forth with DOJ, and then did a document merge to get the red line that I presented so that it wasn't mixed up and you couldn't tell which things are my edits and which things are DOJ's edits. So it's possible that some stuff got confused in the document merge. But yeah, I think that language should still be in there from a pharmacy benefit manager. And if the pharmacy benefit. So I'll look through, Lugina, if you're able to kind of just send me these are the lines where I think this is a problem, like that would be helpful for me.
Absolutely.
So
Absolutely.
yeah. Okay. Other thoughts on sub 7 MAC pricing? I'm behind schedule for my designated public comment window. Is there any member of the public who is not a RAC member who would like to give comment on anything? Please raise your hand now. Your virtual hand. Okay, not seeing any. So I'll go ahead and move forward. I am not done with this rule. What is next? What is next? What is next? What is next? I covered pretty much everything under here. Subsection 8. So this is kind of pointing back to what's the bill? It's from 2023, House Bill 2725. And this is reflecting a couple things. There's language that was in the statute previously saying you can't adjust or reduce payment retroactively on a claim. I think all that was added in 2725 was you can't charge a fee after the fact, and kind of trying to get down to, and there's language specifically in there about point of sale as kind of the term. So this is kind of what I've been trying to do here. We didn't do rulemaking following 2725 because I thought it was clear enough on its own to say you're not allowed to charge a fee after point of sale. We've had complaints since then, which suggests to me that there's at least a perception that PBMs are not in compliance with this. And so I'm kind of looking to come in and say, this is what we think this means. And try and avoid any future confusion on that subject. So that's what this is. So subsection 8, pulling over the language basically straight from the statute, PBM may not retroactively deny or reduce payment on a claim after the claim has been adjudicated unless a fraud with a definition, which is in the statute. A fraudulent activity, I believe, is defined under 540. Payment was incorrect, and then all these sort of exceptions. Payment was incorrect because there was a duplicate payment, or incorrect due to agreed upon clerical error. Those are the only reasons that adjustments are allowed. This is all pulled over from the statute. And then sub 9, I've added a definition looking to kind of resolve potential confusion about 2725, which was the post point of sale fees. for the purpose of the subsection. Point of sale means the time that the claim was adjudicated. And certainly if people quibble with whether that is the appropriate time to say point of sale is, like, you're welcome to tell me, and I'm happy to admit that I'm possibly wrong about this, but that's what I was trying to get at. I know that there was a lot of talk about DIR fees in the legislature, which are in Medicare Part D, and we don't have authority to touch that. And Medicare Part D is not covered by the PBM statute. So, and yet the bill passed. So if there are other fees that are out there that are not DIR fees that are being imposed point of sale, then 2725 would ban that. And I'm just trying to get this into the market conduct rule so that we have clarity on everything that is allowed or not allowed. Okay. And so, like, from everything I heard in terms of legislative intent about these two sections of law and the times that they were passed, is that the whole intent is that when a pharmacy is paid, that they should get, for a given claim, the amount on the check should match that, basically. That is my read of the intent. So no post adjudication reductions or changes or adjustments that are downward, and no fees that are being taken out of your check, so that when you are planning ahead for what getting paid, then that's actually the same. I think there's a potential confusion here that came out during the work group over the summer with Representative Nose, that sometimes the lack of clarity and the fees that are being taken out are perhaps being related to a lack of transparency between a pharmacy and its PSAO, which is mediating that stuff, that the check that comes out that's less than you expected was issued by the PSAO and not by the PBM or the insurer. And that's kind of where some of the confusion is coming out of that. So maybe there's room for future legislation or conversations about that, but I'm trying to at least clean up the statute as it applies to PBMs and what our expectations are. Okay, Legina, go ahead.
Sorry, just having to unmute. A question for you on number 8. You have the subs A, B, and C, but in the statute, you're missing C. The C that's in statute says services that are improperly rendered by a pharmacy in violation of state or federal law.
Mm-hmm.
And then the clerical error thing is D. So I just wasn't sure what the thought process was on that.
Let me double check here. I think that may have been deleted in 4149.
No, it was actually there was some language that was added. It used to say services were improperly rendered by the pharmacy, and then in 4149 it added in violation of state or federal law.
Okay,
that's on page 4. I just didn't know why.
There it is. Yeah, no, that's just an oversight from me in terms of how I was carrying it over. So I will add that in.
Thank you. And then the other thing I wanted to ask is also in 4149, which is still page 4, and it's existing code, where it says that we are allowed to do those post adjudication adjustments if it's because of an audit, and so it's in statute, but it wasn't referenced in the rules. And so I just wanted to ask what the thought process there was, because again, the process was, we still want to be able to have audits and be able to take action if needed.
Yeah. If I had to guess, the thought process was I was very tired when I was doing this and did not translate all of the language perfectly. But let me see here. Yeah, no, I see what you're pointing to. May not be construed to limit pharmacy claims audits. Yeah.
And then we negotiated all kinds of audit stuff. So
yeah. And like, well, I'll talk about audits in a second because I didn't draft anything related to that. But yeah, that's a good call out. That's specific, and maybe I think the thought process was like I didn't fully calculate, I didn't fully grok what that clause meant when I was drafting rule language, and so I didn't carry it over. But yeah, that's something I can add and maybe add some clarity on. Any other discussion on?
Sorry, one other thing.
Yeah.
I'm so sorry, because you did 8 and 9. So
Yeah,
on 9,
yeah.
and actually this might be a question for Austin and Amanda and the other folks on the phone, but you're defining the purposes. It says for the purposes of this in number 9, for the purposes of this section, point of sale means the time the claim was adjudicated. And you mentioned something about that there were some discussions about fees being imposed. I guess I'm just trying to understand what we're trying to get at. Because to me, point of sale is when you actually sell the drug to the member, versus adjudicating a claim is when you're processing it, but it could still sit there for, a couple of days until the patient comes to pick it up. So I just wanted to just see if I could get a better understanding of what the issue was, because I just didn't recall that.
Yeah, sure. I mean, like I said, most of the discussion around 2725 was related to DIR, which again, I don't know that we have any real scope of authority over. So that's out there. As far as other fees go, like, I mean, sure, like I can imagine there being other fees imposed after point of sale that are then resulting in a smaller payment than was expected. But like I don't know what they are. So if I would be certainly open to alternative definitions for point of sale that I can put in here, if people have any. John, did you have a thought here?
Yeah, for a pharmacy, for me, filling a prescription, the adjudication time is really when I know what I'm getting paid from the PBM. And so that really does make a difference to me. If they sit on the shelf for a short period of time, there's an allotted number of days that they can be on the shelf before we have to reverse them back out if they haven't been picked up. So really adjudication or reverse adjudication is done. And it's the fees that come out afterwards that are an issue to us, the DIR fees, we talked about. When you get to talking about the PSAOs and the generic effective rate and brand effective rate and equalization across networks and things like that, that's when the PSAO might pay less than you have on your adjudication record, those kinds of things. So, but for a pharmacy, it is nice to know from the PBM perspective that when we adjudicate it, this is what we'll get paid. We will follow through with reversing and all those kinds of things.
So is it most useful to you for this to kind of stay as it is, or would you suggest something else?
I would leave it the way it is,
Okay.
unless some of my other compatriots and independent pharmacy or something would speak otherwise to it.
Austin.
I also vote keeping it as is at the time the claim was adjudicated. There's other rules that are written, like when we do DIR, they say we have to do it at the point, DUR, they say we have to do it at the point of sale, which essentially is when you're doing the final verification, which essentially is when the claim is adjudicated. So that term is used, point of sale, to mean a couple of different things, but here it makes the most sense to be when the claim was adjudicated, because there's no reason why there would be a fee there's no reason why a fee should be imposed after the point of sale. That should be when the copay is printed on the label. We know what the final payment to the pharmacy is. That should be what it is. I don't know why it would be any different.
Okay, that makes sense to me. Amy?
I agree. We're just agreeing. I agree.
Love it. Well, okay. Cool. So that is maybe cleaner than I thought it would be. Okay. Subsection 10. Mandatory mail order ban. This is from 2185. We didn't put it in the rule. I think it should be in the rule, just for clarity. I know that we've received complaints about mandatory mail order, but they related to, as described previously, a insurance company that was acting like a PBM. So we didn't have enforcement authority because, as defined, they do not qualify as a PBM. Okay. Subsection, yes, Legina. Muted. Sorry.
Apologies. On 10, I just wanted to inquire, certainly this language exists, but there are exemptions for specialty drugs, and it's not included in the rule. So I was wondering, it was confusing because when you read it, you're like, I can't do this mandatory mail, but they're very clearly exemptions for specialty that we need to preserve and protect. So I'm
Yeah.
just trying to, I just wanted to ask, why the exemptions weren't included, because I think it really helps people understand.
Yeah, no, that's a good call out. I can carry that over in some form. Yeah, I mean, ultimately, when we put rules out, the statute is still the controlling authority. So if there's a conflict, like it's like, okay, that exception still technically exists. But kind of part of this whole exercise is that I think one of the things that came out for me of Representative Nos's work group is that there's a perception from my part that parties on both sides to some extent are relying on the rule as the primary source. And so that was one reason why I wanted to kind of carry over things that had been left behind. So like, I do remember that exclusion language, and we'll figure out some way to put it in, even if it's not necessarily as wordy as what is in the statute. Maris.
Yeah, I was just going to echo what Lugina said, and I appreciate that, Numi, that I think it would be valuable to carry that over to make it very clear that that specialty is included. So thank you.
Absolutely. Okay. Okay. 10 or 11? 11. 11. So this is non-retaliation or retaliation ban, I guess I would say. So this was put into the statute somewhat weirdly. That the clause that was modified by 4149 related to gag clauses originally, and that was before there was federal action that made basically the state law on that irrelevant. So the way that this was drafted in statute was saying PBM may not penalize a network pharmacy for here's a list of conduct. And basically kind of defining what that means, and then saying by appealing reimbursement, by filing a complaint with DCBS, by engaging in legislative process, there's been certainly allegations made that PBMs have directly retaliated against certain pharmacies for testifying before the legislature in various ways, or otherwise challenging a PBM's practices. So the way that I've structured this is pretty much all this language is in the statute. It's in a different order though, in that I've listed the conduct first, so protected conduct basically, and then I've defined what penalized means for the purpose. The main thing that I've added here is audit, because that's been something that's been called out specifically, is that that PBMs have conducted audits of a particular pharmacy in response to engaging with the legislature. So that is an allegation that has been made. Whether or not it is true, certainly I know that wheels are in motion internally in corporate entities that may not respond so quickly. So that's what that is. Kind of the other thing that I tweaked here was basically to try and have a limiting factor, is to say that penalize applies if the pharmacy that is engaged in the protected conduct is being treated differently from other pharmacies. And so that's why I've got penalize includes but is not limited to any of the following actions if applied to a network pharmacy engaged in conduct described differently from network pharmacies that have not engaged in similar conduct. To say that, you know, like you do not violate the statute just by auditing a pharmacy. You potentially violate the statute by auditing a pharmacy selectively in ways that are not consistent with practices otherwise. Just to kind of say that is the limiting factor here. So again, I'm open to criticism that this is not a perfect way of translating over this intent, and that one of the things that I'll mention here is that we do have more or less, we have good authority to rely on to say that we're going to add audit here because where is this in the statute? It's under market conduct somewhere. May not otherwise directly, that's the gag clause language. Filing an appeal. Oh,
So, you know,
the audit is because
where is
it
it?
says, hang on. Otherwise retaliate is the language I'm hanging my hat on for that. Is to say otherwise retaliate could potentially include audits, but also is not limited to those things.
Numi, I don't think that was the intent though. I mean, like audit is very specific and we don't set up audits that quickly to retaliate against somebody for testifying. And I, you know, I mean, thanks for giving us that much credit, but you know, it's not how it works. So I think I would be opposed to audit language being included because it's not specific in here, and auditing that's not how auditing functions. So I mean that was my question though, because where is auditing specifically in the statute, and it's not. So
yeah,
I think
it's not. It's just that is something that
you'd need to be able to give an example of how they're being audited is in direct is a retaliatory action.
Yeah,
Because you know, I know that some have claimed that, but like they've never given any specifics on, you know, or the PBM was not asked why the audit was occurring. Like there was never like specifics provided after that. It was just stated by one person and then assumed that was retaliatory.
Yeah.
So I feel like we're going on assumptions here and not the law.
Yeah. I mean, I have a couple of thoughts. One of which is like, I think it would be difficult given the other provisions of the statute for a PBM to realistically use auditing as a way to punish a particular pharmacy for engaging in conduct because of the restrictions on the number of claims, absent arguing fraud in a way that is unreasonable. So like you're limited to what, 250 claims per year under the new statute for both desk audits and remote audits, or both remote audits and on-site audits. So like,
unless it's fraud.
Unless it's fraud, and unless there is clear evidence presented of fraud to justify that. So it would be difficult for a PBM to actually engage in that sort of conduct in a retaliatory way, because it's not like you can go in and say, I'm going to audit high school pharmacy 10 times this year, and everybody else I'm only doing just according to our ordinary random schedule. Like that would be the sort of thing that it's like, okay, this clearly looks like retaliation against a particular pharmacy, but it's not possible to do that without violating the other provisions of the law already because of the limits on the number of claims per year. The other thought in terms of like what would be something that would be proof of that a pharmacy or that a PBM could present to say, it's like that a pharmacy could present about a particular PBM to say this was a retaliatory audit. Well, it would have to be something where you had deviated from your normal audit schedule to advance high school pharmacy to the top of the list, for example. I think that it would be difficult for the pharmacy to actually obtain the information to be able to say this is what happened. Like, certainly we could receive a complaint that said, I went and talked to Representative Nose and I got audited the next day. And like, that is something that has led to the perception of that. I think like reflecting the interests of stakeholders, that like it makes sense to include on the list of possible things, even if I think it is fairly unlikely that audits per se could be used in retaliation, that because it's been something that's been raised and concerned to the legislature, that is something we would want to include on the list of possible conduct, even if it's unlikely that it could be used in such a way. I've talked myself in a circle now. Jen, if you have more thoughts, like we can wrap around. Let's go through my remaining hands.
It's not in specifically in the language, and so you're also agreeing that it's unlikely. So putting it in the rule seems like we're going above and beyond the boundaries of the statute. So
you know, it's like sometimes my audience is specifically Representative Nose, for example. So an audience of one, two.
But I mean, like, that's the thing. He's going to have his own bill, so why not put it in the bill? If that's, you know what I mean? Like, it's not in the, it was not in 4149. So that's
Sure,
all right.
sure.
That, you know.
No, I mean, I hear that. Like, I'd certainly be interested to hear from the pharmacists if they think it makes sense to put in there, and recognizing perhaps that it is unlikely that an audit could be used in such a way that that's out there, whether it makes sense to keep in. And like, this is not a group that I necessarily expect to get consensus on everything. So to some extent, like, this is an advisory body, and, you know, we put in rule what we put in rule in the end, and maybe somebody sues us. Hopefully not, but maybe. So let's go ahead. I've got 3 more hands. Lugina, go ahead.
Thanks so much. On 11, just a general question. So this is just 11 where it says we can't penalize a network pharmacy for, and then it has all the listings of things that we can't penalize for. You mentioned gag, which is in statute, but it's not here. Is that intentional? I mean, I know there's federal law. I just wasn't sure why it wasn't included as one of the reasons. So I'll pause there and let you, and I have one more thing.
I think that was intentional on my part, because I think that it's effectively superseded. So like, I didn't see any reason to put it in the rule, because then it's like, this is an exercise to try and reduce confusion. And I think carrying over redundant language from statute into the rule increases confusion.
All right. I just don't want anybody to think that we could do that, because we wouldn't do that. But okay. And then on F, where it talks about the penalizing and things of that nature, I think the legislative intent was always like a lot of these things, whether it was you know, in changing contracts, terminating contracts, a lot of those things happen in the normal course of business. And so what we were trying to get at, and with my understanding of the legislative intent, was like, you know, these things happen in the normal course of business, but if these things are happening at a frequency that is not comparative to, you know, a similarly situated pharmacy, then certainly that would be something to look into, to be like, are you retaliating? So, and I appreciated you explaining the network pharmacy and that have not engaged in similar conduct, but I didn't know if maybe similarly situated pharmacy might be helpful here, because first of all, we've used that previously. And that's a way to make sure that, like, for example, maybe the audit frequency of a retail pharmacy is different than the audit frequency of a long-term care pharmacy. So they're both in network, but they have a different auditing frequency based on, you know, what lines of business are operating in those different things. So I just didn't know if maybe similarly situated pharmacies might be helpful here.
Yeah, thank you. That's a good suggestion. I don't remember if we have a definition for similarly situated pharmacy anywhere. So that might be something that I would want to check against before moving forward with it. But like certainly if there's interest in using that language instead of the sort of blanket network for other network pharmacies, like you know, like I am trying to get at the, you know, all of these things, whether it's an audit or a fee or, you know, chargeback or changing contract terms. Those are all things that are going to happen, period. It's just kind of like, are they happening in a way that is different?
And I will say, and I just to one final comment. The conducting an audit of a pharmacy was concerning language because I didn't know where that came from. It wasn't one of the, you know, it wasn't specified in 4149. I understand that there has been some concern about it. But again, I just want to make sure that we are protecting our ability to audit, you know, should something be awry, as well as, you know, just normal course of business. So.
Yeah.
Thank
you, Legina. John.
Thank you, Numi. I guess I'm supportive of having audit in there only because that is one of the chief complaints. But I'm also supportive of the comment that, and I apologize, I didn't get your name, just made about similarly situated pharmacies, because the comment was made, well, how does a pharmacy prove or gather evidence that that's the case? Well, we can't talk to other network pharmacies by contract, and so, or by law. Well, we could, other similarly affected pharmacies we would be able to gather information more easily to make a comparison. As far as whether audit activity around, say, political activity at the legislature is happening, I have plenty of history that I can show you on audits, dollar amounts, frequency, different PBMs, how they've been conducted in the past, and if they suddenly increase in frequency around any of these activities, it would be easy to demonstrate. And so I guess I'm supportive of that language, including audit in here. But my second question is, you know, back to our previous discussion about MAC, where's the penalty? What is the penalty here for a PBM that might retaliate to, I guess would be my next question.
Yeah, again, that would be the authority we have is under sort of license revocation, previously registration revocation. And then we do have the general civil penalty authority under the insurance code, which is up to $10,000 per violation. I think another thought that I had was that, you know, I've stood up a few programs now, and the discussion of penalties for compliance always comes up. How much should that be? There's a relatively unusual program as Drug Price Transparency has all of the sort of penalty schedules written out in great detail for particular types of conduct. That's not usually how we do things. Generally, there was a particular legislative interest in the ways that penalties could be applied in that program, and so that was something that was done differently. Normally, we kind of leave it up to discretion of our enforcement teams who, you know, use penalty negotiation as a leverage to get settlements, is one thing. So that can be something where even if I said, like, you know, if you have complaints that relate to 10,000 underpaid claims, and where there's clear violation of the MAC law demonstrated, that would be something that comes out and we say, okay, here's 10,000 claims, that's $10,000 per claim. This went on for 40 days. That's a big sum of money. That's a big check. In terms of retaliation, you know, maybe that $10,000 mark doesn't seem that impressive if it's kind of like, okay, well, you had I won't talk about audits because that's a sore spot. If you were hitting, if Murray Drug was getting hit with a bunch of contract amendments that nobody else was, like, then each one of those contract amendments could theoretically be a violation under this section. And then it's kind of like, okay, it accrues based on, you know, after we say, okay, here we've made a determination, we think this is a retaliation, this violates the statute, and then there would be however long it goes on. But yeah, it's not as meaningful perhaps as the sort of accumulation for underpayment, if you can demonstrate thousands of underpaid claims, for example. Amy, go ahead.
Yeah, just kind of a suggestion to, excuse me, maybe keep the language audit in the rule here, because I think that the perception is real. Perhaps if we use something like unwarranted, some sort of qualifier, unnecessary and unwarranted, something like that, an unnecessary or unwarranted audit of the pharmacy. And then it's kind of the onus is on being able to prove that that audit, was that really scheduled? Like I heard an audit the next day, something like that. So I don't know. Maybe there's some kind of language on there to explain it a little bit better, because obviously audits have to happen. Yeah. So it's the, retaliatory situation that we want to express here.
Okay, thank you. That's helpful perspective. I'll consider what we can put into. Austin, go ahead.
My only vote is that we need protections where we can get them. Pharmacies are sitting ducks. I forgive the example from another state, but I was required to re-credential for a PBM, and in Washington, they're not allowed to charge for re-credential fees. I emailed the PBM and said I completed the re-credential, I paid the fee, the $150 fee, and I said, this is in direct violation of RCW whatever. A pharmacy benefit manager may not charge a pharmacy a fee related to credentialing. Their response was, thank you for your inquiry regarding the recredentialing fee. Blank PBM is willing to waive the fee in the event that you are only seeking to service beneficiaries of plans subject to Washington state. However, you wouldn't be able to bill Medicare or TRICARE. So essentially they're threatening me to say that, well, we'll refund you your $150, but then you're not going to be able to fill for Medicare or TRICARE anymore. You can only fill for whatever plans are within the state of Washington. That's why we need these protections, is because this is from last week. And so I've already got the complaints in with the Washington Office of Insurance Commissioner. So we're sitting ducks. We need these protections where we can get them. That's my comment.
Okay, thank you, Austin. That's helpful perspective. I don't see any additional hands on this, so I've got a few tweaks to make to the language on this, and I think what I'm leaning towards is leaving audit in there, maybe with some additional language like Amy had suggested, just to kind of narrow things down a little bit in terms of where this would be applicable. But like noting something like credentialing fees, or like forcing recredential, like that's not in this list of things, but it is under including but not limited to, and it is in the statute under otherwise retaliate. Like if you can prove that something is being discriminatorily done against a particular pharmacy who's been doing something, then that would be something that could be demonstrated to be retaliation in violation of that provision of the statute. Let's see here. It is 2:47. I had at least one other thing I wanted to mention. Yeah. So audits. I promised that I would talk about audits a little bit. There's a bunch of tweaks to the audit provisions. My understanding of that was kind of to try and update the statute in response to changes in PBM practices that happened during the pandemic, which was a switch from primarily in-person audits to primarily remote audits. And that the limits that were originally negotiated back in the bill in 2013 applied to in-person audits, but not to remote audits. And so it kind of tweaks some of the frequency, amounts of claims, and brings us into brings it in so it's applying to audits regardless of whether they are in person or remote. We did not have a rule that kind of delineated out the audit stuff previously. I think the most logical place to put that language, if we were to add it to rule, would be probably under the same market conduct statute, rather than creating a new rule title. Part of the reason, so there's kind of two reasons why I haven't drafted something that brings in the audit provisions of the bill. Which, what is that? That is section 9? No. Section 10 of the bill, 735, 542 changes. And there's some notice requirements in there. Part of it was like, I think the statute speaks for itself sufficiently here. And part of it is we don't have a rule title that incorporates the audit provisions of the statute. And it would be more of a pain for me to create an entirely new rule for that. So I'm open to trying to carry over the limitations on audit into the rule in some form, if people think it's necessary for clarity in some way. But otherwise, I'm just inclined to say that the statute speaks for itself in terms of what was negotiated in 4149 in the last session, and that if there are problems that come up with enforcement of those provisions, then we would consider doing rulemaking to bring that into clarity in the future. But I don't think it's needed right now. Any discussion on that? I see some shaking heads, so, and I don't see any hands. So I will say that I will save you the problem, the headache of looking at audit rule language later next month, by leaving it out of the rules for the moment. Okay, that is all of my draft rules. We did it. Yay, it's 2:50. Do we have any members of the public now who would like to give comment now that I've finished? Please raise your hand. Okay, not seeing any. Next steps. I have somewhat ambitiously decided to try and get this rulemaking done with 2 RAC meetings. So I think we have another one on the calendar. Karen, can you tell me when that is?
Let me look it up. I don't know off the top of my head, so give me a moment here.
Hey, I found it, I think.
Oh, good.
November 20th, which is 3 weeks, at the same time, same time slot, 1 p.m. to 3 p.m. Yes. So that, yeah, go ahead.
What this is terrible, but Portland Public Schools have to, they're doing their early release that day because of the strike from last year, and so some of us have childcare. So if you could start at 1:30, it would be extraordinarily helpful. Like just like ours is 12:45, so like I don't know if I could. It's not that big a deal, but I'm just putting them out there.
Okay.
Yeah, thank you. Yes. So 20th, but otherwise 20th seems okay for most people. Regina?
Sorry, just a process question. So in the previous racks that I've been involved in, like this one is like usually where you guys kind of present like what your rationale was and why the words are that are on the paper. And then we can go back and kind of like digest it, submit comments to you, and then have those comments shared with folks ahead of the 10/20 meeting, so we can kind of see like, you know, what was the pharmacist's thoughts and what was the PBM's thoughts and what was the insurer's thoughts, and then we could have a really good discussion on the 20th. Is that what the approach we're going to be using, or is the 20th where we would just come in and you know, now that we've had, you know, more than a couple of days to look at it, is that where we kind of bring up more suggestions or thoughts?
Yeah, so I think I'm my preference would be towards the first way that you described, is to give an opportunity for feedback now. And, you know, like that I'm going to take time with the verbal discussion that we've had and try and make the edits that I've said, whether they're substantive or more like just drafting errors, and get all that incorporated into a draft rule for presentation, and then also to collect written comment from anybody who would like to submit it, both members of the RAC and if members of the public want to send me letters, they can. I will give them less priority than letters from members of the RAC, but you know, putting that out there. And incorporate anything that we think that our internal consensus is, okay, yeah, we think these are good changes, get that into the draft, and then give folks the opportunity to speak their piece in the meeting on the 20th to say, like, here's what we sent in, here's why we think that, etc. Here's our idea, here's our definition of whatever term. And then for me to go through sort of my updated draft, have discussion on that similar to what we did today. And then if it seems like we're at as close to consensus as we can get, then we would potentially have a third meeting if it seems like there's still a lot of things that need to be ironed out. If not, then, you know, it would be like, okay, this is as much agreement as we're going to get on these things, so we're going to move forward with what we have. Sort of just in terms of timeline, like I had put off starting this partially because like I was hoping to get more staff for the program in place before we really dove into this. And so that has meant that I do not have time to jump through all of the legal hoops to get a permanent rule on the books on January 1. So kind of my hope is to get something that is ready to file as a temporary rule, which will be effective January 1, because of the way that the statute is written, that can be in effect for 6 months. So the goal then would be to file a permanent rule in March, so that would be effective on June 1st, and then we'll move forward. My hope is that we'll be able to get something that we file as a temp rule that is basically identical to what I'm going to be filing as the permanent rule in March, because I do not want to be working on this in January because there is a legislative session happening this year. Whether or not that is possible, you know, like, it wouldn't be the first time that I've pulled a RAC into January and filed a temp rule for a new program, and had the permanent rules with significant changes ultimately. Thank you, Jen. Significant changes in place for June. That was also pharmacy related. That was licensing of pharmaceutical sales representatives. That was a fun one too. So I'm rambling now. Hang on. Let me refocus.
So how about if I ask this question? So
Yes.
Our next meeting is on 11/20. It sounds like
Yes.
your preference is for us to provide written comments that are more thoughtful and succinct.
Yes.
What date would you like for those to be submitted so that you can get them and distribute them to the RAC members prior to 11/20?
How do we feel about Monday, the 11th of November? That is a week and a half from today.
I mean, it's a holiday.
Is it? Oh,
It's Veterans Day.
Veterans Day. Oh, yeah. How about Tuesday, the 12th of November? Close of business Tuesday, the 12th of November. And then we'll get stuff circulated by the end of that week. I will be traveling that weekend. I'll be at NAIC over the weekend of the 18th, but we'll make sure to read everybody's comments in my hotel room and get any additional revisions in place before the 20th. Okay. And we will also review our statement of need and fiscal impact at the next meeting. So that'll be additional piece of materials out there. I would certainly, so that one's normally a little bit pro forma on a lot of our insurance rulemaking because it's kind of about impacts on small businesses. And when our rules primarily impact insurers, none of them are small businesses. Pharmacies can be small businesses in some cases. And so certainly we would be interested if there is a potential burden on pharmacies as the result of these rules, even though the primary regulated entity is the PBM. So that would also be something I'd be interested in hearing about. So comments on anything, I would love to receive comments on the sort of definitions which I asked about. Would be appreciated if people have suggestions on the similarly situated pharmacy or what was the other one? Pay for performance, similar means. That was, we have stuff in statute that I need to look up. I feel like there was another thing I asked for a definition of, but I can't remember what it is right now. And I'm about to go over time. So if anybody has other questions, like feel free to send me an email. I'm easy to find. Please get me any written comments you have by close of business on the 12th. Would welcome feedback on people. If people think there's impact on small businesses as a result of these rules, please tell me. Primarily focused on the negative side, but either way. Definitions for the terms that we discussed and any other comments. Okay. Any need for clarification on anything? Thank you for having a very civil conversation. And I will see you all on the 20th, if not sooner.
Thanks.
Thank you.
Thanks, Numi.
Thanks, Numi.